Good evening, everyone present here. I am your host Faraz from IGCP Med Talks. It's my great pleasure to welcome all these team participant doctors for joining this session across the country. Let me introduce today's topic. Today, we dive into the compelling and timely discussion in the field of preoperative care. And for today's session, the topic is opioid free anesthesia myth, method, or the future. As we navigate the complexity of the pain management and the ongoing concern regarding opioid related side effects, exploring this alternative is more critical than ever. As we know that this topic is very much important, so we need someone expert. So to lead this session, we are incredibly honored to have with us true stalwart in the field of anesthesiology. He is none other than Professor Dr. Nishant Kumar sir. We all welcome you, sir, for this amazing talk show. And let me share some of the achievement of sir. Sir has done MBBS, DNB, and is a member of National Academy of Medical Science, and he currently serves as a professor in the Department of Anesthesiology at Lady Hardinge Medical College and Associated Hospital, New Delhi. Beyond this, his impressive credential, Sir is widely recognized for the academic excellence and his dedication to advancing patient safety and innovative anesthetic technique. So, without any further delay, I would like to invite Sir and hand over this webinar to Sir. Sir, the stage is yours. You can proceed from here. Over to you, Sir.
A very good evening, and thank you, Farad, for the kind introduction. So, we'll be talking about a very important topic today, opioid-free anesthesia, whether it's a myth, it's a method of anesthesia, or probably the future. So, first we have to understand, why do we talk of opioid-free anesthesia? Why do we require that? We all know that opioids was probably opium was one of the first anesthetic drug solely used for the purpose of surgery and other procedures. It is an age-old drug which is available widely in nature. People have been consuming it for analgesia, as a medicine, and for recreational purposes as well. So, why are we now ditching this centuries old drug and we are moving towards other drugs? So, the simple reason being, that the administration of opioids is a double-edged sword. Why? When we talk of anesthesia, we talk of three components of anesthesia, that is the amnesia, analgesia, and areflexia. So it is the analgesia part which is taken care of by the opioids. They provide somewhat a mild sedation, no amnesia, and in conjunction with other drugs, they might provide areflexia as well. So it's a double-edged sword. Why it is a double-edged sword? We all know the benefits. It's an excellent analgesic. We had longer acting like morphine. We have shorter acting like fentanyl. They are very good for your cardiac conditions, and they provide stability over a wide range of surgeries. In fact, whenever we say that the patient is unstable and we want to have stable hemodynamics intraoperatively, we prefer opioids. So why are we moving away from opioids? Because being a drug, because of apart from the benefits, it has certain side effects also, and sometimes the side effects override the benefits that this drug provides. So the acute risks are postoperative nausea and vomiting, which is very intense after opioids, the chances of respiratory depression, paralytic ileus, urinary retention when given in the neuraxium, and also it has a paradoxical effect. As I said, the opioids are known for their analgesic effect, but then in certain patients, they might also cause hyperalgesia in the postoperative period. Also, since, as I said, they have been used for recreational activities and they have some potential habit uh, forming potential, and uh, it has a potential for misuse and chronic use. So, because you develop tolerance and then it becomes a habit. And the main thing which is coming up now is that the opioids cause immunosuppression. Also, there is a concern regarding cancer recurrence when used in cancer surgeries. So, all these, if we see, ultimately, these are cheap drugs. But then, when we take all these factors, the side effects that these cause, it increases the ultimately the cost to the patient and to the healthcare system. So, before moving on to opioid free, let's see some definitions. So, the traditional approach is the opioid based anesthesia, the OBA, in which we use opioids as the primary analgesics, be it morphine, be it petidine, be it fentanyl, C-fentanyl, remifentanil, and others, then this is the when your analgesia is solely relying on your opioids. So we have the maximum opioids in the intraoperative period, that is your maximum opioids or opioid-based anesthesia. At the far end is when we don't use opioids at all, that is opioid-free anesthesia. It is you're not using opioids at all. So what are the drugs that we are using? We'll come to that later. And then we have something in the middle which is called as the opioid-sparing anesthesia, in which you use agents and you use opioids either in low dose or only when they are actually required. So your analgesia is not solely based on the opioids. It is a multimodal analgesia, but you may use some amount of opioids. So we have three definitions here: the opioid-based anesthesia, the opioid-sparing anesthesia, and the opioid-free anesthesia, which is zero opioids. Now we all know that the noxious stimulus, it goes to the spinal cord, dorsal root ganglion, then through the spinothalamic tract into the thalamus, into the cortical sites where the pain is perceived. So the opioids, they target the central mu receptors and to some extent the peripheral mu receptors as well. Uh, the peripheral signaling is not blocked that much. Now, whenever we talk of other drugs, then there are some minor pathways also which are not blocked by opioids. It is mainly the central effect, the mu receptors and the kappa receptors, which cause the analgesia. But then there are certain other pathways which may cause pain. So we have the COX-1 and 2, the sodium channels, and the NMDA receptors, alpha 2 receptors, and then we have the in the brain, that is, the transaction is by the peripheral effects are by the COX-1 and 2, the sodium channels and regional blocks, which again block the nerve conduction. Then transmission and modulation by NMDA and alpha 2 receptors. And then in the perception, we have lignocaine, dexmedetomidine, and gabapentoids, which act mainly through the calcium ions, blocking the receptors in the brain. So when we talk of opioid-free anesthesia, we are obviously saying that we are not using any amount of opioids whatsoever. So what are the alternatives that we have? We have the alpha-2 agonists which act centrally through the alpha-2 receptors, which cause sympatholysis. The examples are dexmedetomidine and clonidine. The sodium channel blockers, voltage-gated sodium channels, which uh, which is given through IV and causes a systemic effect, that is the IV lignocaine. Remember, this is a preservative free that we use as an antiarrhythmic also. The gabapentoids, which act on alpha 2 delta subunit of calcium channels, we have gabapentin and pregabalin. NMDA antagonists, which are ketamine and magnesium sulfate, which prevent central sensitization, anti-inflammatories, that is COX inhibitors and prostaglandin inhibitors, NSAIDs and paracetamol. Then we have regional anesthesia, which block the direct nerve conduction and again act on the sodium channels. So this is the armamentarium whenever we are talking of opioid-free anesthesia. So just to give an overview of the dosages, whenever all these drugs can be used individually or in conjunction with other drugs. So dexmedetomidine, usually we give a loading dose of 1 microgram per kg, followed by an infusion of 0.2 to 0.7 microgram per kg per hour. Ketamine, again, we give a bolus of 0.5 to 1 milligram per kg, and then depending on the pain stimulus and the nature of the surgery, we can give anywhere between 0.25 to 1 milligram per kg per hour of infusion. For lignocaine, we give a bolus of 2 milligram per kg, followed by an infusion of 1 to 2 milligram per kg per hour. And obviously, all these can be combined with regional anesthesia adjuncts such as magnesium sulfate. Then we have the NSAIDs and paracetamol. So all these drugs can be combined in various combinations, as we'll talk later. So what are the benefits of opioid-free anesthesia now? So these are the drugs used. So why are we using opioid-free anesthesia? How does it benefit over the opioid-based anesthesia or the opioid-sparing anesthesia? Now, these are based on various studies. So if we see the probability of causing postoperative vomiting or reduction, in other terms, how much the reduction is there. Obviously, opioid based, we know that opioid is going to cause nausea and vomiting. So that is the control group. When we talk of opioid sparing, so if we reduce the opioids to only when indicated, the reduction is as high as 50%. And if we are not using any opioids whatsoever, the chances of having post-operative nausea or vomiting reduce to come down to only 0.6%. So only 0.6% of the population is likely to have postoperative nausea vomiting when the opioids are entirely omitted from the anesthesia regime. But then, obviously, it causes significant postoperative nausea and vomiting postoperatively. Also, why postoperative nausea and vomiting is so important. The most common cause of readmission in this hospital stay and patient discomfort after surgery is the uh, postoperative nausea and vomiting. So there have been many studies, various reviews, Cochrane reviews, and everything. So postoperative nausea and vomiting is the single most factor which prolongs hospital stay, delays recovery, increases healthcare cost, causes readmission, and uh, decreases the patient satisfaction. But then there are certain side effects of opioid free techniques, whatever drugs that we are using. It might introduce some amount of hemodynamic instability. That is one of the side effects. If you are using very high doses of other agents and opioids, it might lead to some amount of respiratory depression. There's a slight increase in PACU stay around 10 minutes due to sedation, but then that is there with increased dosage of opioids as well. And as compared to fentanyl or remifentanil for that matter, the emergence might be a bit delayed as compared to remifentanil. When we talk of short acting opioids, obviously we are talking of remifentanil rather than fentanyl or morphine. But then again, if you are administering a long acting opioid to prevent the effect of opioid induced hyperalgesia and to take care of postoperative pain when using remifentanil, I think the PACU stays would almost be the same. So you have to keep a balance. Then, when we talk of pain for which these drugs are being used, now opioid free anesthesia does not guarantee better pain. That means it is not over and above the opioid. So, uh, but yes, it causes comparable pain. That means pain relief. So that means that whatever analgesia that you're going to get with morphine or fentanyl or remifentanil, the same analgesia you'll achieve by opioid-free regimen as well. So if you see no significant difference in 24-hour pain intensity, comparable rescue analgesic requirements, and that means the side effects of opioid-based anesthesia are reduced while comparing comparative or even sometimes better effect. Now, where to use this regimen? In bariatric surgeries where opioids might have a really high impact. Why? We don't want the patient to vomit. Why? Because they have cut the stomach, so retching and all will have an effect on surgical this thing. Then VAS, if you see here, 24-hour pain score was much lower than the opioid based, although it was less than 4, but then much less with your opioid free technique. Similarly, orthopedics, morphine use, a reduction of 15 milligram, ambulation is sooner. Then in thoracic surgery, length of stay is decreased and no incidence of uh, respiratory depression, which is again a complication in thoracic surgery because the lungs have been operated upon. So overall, over a wide range of surgeries, and these are all high-risk surgeries. So if you see here, the opioid-free anesthesia performs better than the opioid-based anesthesia. Now coming to the recovery. So we see that the emotional state is slightly better with opioid-sparing anesthesia rather than with opioid-free anesthesia. Why is that? Because as I said, opioids have been used for recreational use only. They provide neuroaffective stress reduction. You are just if you have heard this thing, opium is used to forget the world or to get away from the world, what is happening around you. So to certain extent, yes, it does produce a feel good effect. All the opioids produce a feel good effect. That is why probably they are so habit forming. And the physical comfort, if you see, was is similar Independence obviously is better with opioid free anesthesia, because then you have less side effects from the opioid based anesthesia. So, overall, when you see opioid based versus opioid free anesthesia, you have better PACO efficiency, the patient ambulizes earlier, and you have a faster discharge readiness, and the quality of recovery score 40 is definitely better with opioid free anesthesia as compared to your opioid based anesthesia, and an increase of 8.3 points weighted mean difference confidence interval 2.4 to 14.2. So the quality of recovery overall is much better with opioid-free anesthesia as compared to opioid-based anesthesia. So when we compare the three drugs, so overall quality of recovery score, we say that opioid-based again as a control, so that is 0. Opioid-free is 64.7. Now opioid sparing, surprisingly, it gives the best balance of comfort and emotional state. As I said, you give a bit of opioid, and then it certainly becomes, the patient feels a bit better. But then, in opioid naive patients, patients who have never taken an opioid, even a few doses of opioids can cause uh, dependence. I remember a case where there was this patient who was opioid naive, a young male. He was operated for laparoscopic cholecystectomy, intraoperative fentanyl, postoperative tramadol, and then that patient followed in our pain clinic for around 6 months to 1 year just to get a prescription of Ultracet, which is a combination of tramadol and acetaminophen, because he said, I'm having constant pain. And the moment you give other analgesics, he said, I'm not comfortable with, I'm having severe pain. So he had to had that 2 tablets of tramadol each day to relieve his pain. So that is, astonishing. And once you search the literature, you'll find it is very common that in opioid naive patients, uh, drug as inexplicable as tramadol can be habit forming. The only thing is that we don't monitor these patients. Tramadol Rosette is widely available over the counter, easily available in India, and we have no data on the opioid interdependence, unfortunately, in our country. Okay, so we have acute benefits, which is reduced PONV, hemodynamic. Yes, you can maintain hemodynamics, reduces habit forming, early recovery, and all those things. Then there are some long time hypotheses, as we have said, that is the persistent use of opioids, whether opioid-free anesthesia decreases the persistent use and a definitive effect on cancer recurrence. Although some studies have shown that it is better than giving opioids, but then we are still lacking data, and probably in a few years from now we would be able to definitely say whether opioids do have a role in cancer recurrence, and whether opioid free will prevent cancer recurrence or not. So it is yet to be seen. So who are the ideal candidates who will benefit from opioid free anesthesia? The morbidly obese, patients who have a high risk of postoperative nausea and vomiting, chronic opioid use, then patients who have chronic pain syndromes and are suffering from hyperalgesia. Contraindications, definitely, because we are using drugs which will depress the sympathetic system to a certain extent and have an effect on heart. So probably a heart block patient, patients who have bradycardia, severe LV dysfunction, uncorrected shock. In these patients, probably opioid-free anesthesia is not the good choice. Um, Dexmedetomidine, lignocaine, and ketamine, these three are definitely this thing, uh, the choices. And if you can tailor, maybe in these group of these are relative contraindications. Remember, these are not absolute in contraindications. You have to be perfect in your you must have practiced opioid free anesthesia before you actually go and use opioid free for these particular patients. These are all relative contraindications. I've used opioid free in severe LV dysfunction. I've used opioid free in bradycardia patients. um, in corrected shocks, yes, we use ketamine for these patients. Heart blocks, yes, I'm in type 2 blocks, yes, I have used opioid free, but not in type 3. So maybe we can go on with that. And definitely, the addition of regional blocks will further decrease the other drugs, and we can have an opioid free anesthesia regime for these patients also. So uh, for opioid sparing, breast cancer surgery, standard general surgery, and patients requiring rapid emergence, yes, opioid sparing might be a bit better than opioid free. So, how do you implement it? So, you choose your patient, you have your protocol ready, you monitor these patients. Yes, whenever you are using opioid free technique, your operative this thing rises, uh, monitoring rises, because there is always a chance of hemodynamic instability. So you have to monitor much more as compared to the traditional analgesia regimen. Also, you're not accustomed to this procedure, so definitely the monitoring, the heightened vigilance is required. And again, discharge stewardship, whether to prescribe opioids, whether to prescribe other drugs, that will depend again on the patient, on the surgery that has been performed, how well the pain scores, how effectively you could use the opioid free techniques intraoperatively. So it will all depend on your um, practice and this thing. Now, why do we need to move away from things? See, this was also anesthesia once upon a time. We need to move away from it. We have to move from blunt force to precision pharmacology. So you give morphine, you load you in morphine, we say hemodynamics are not going to waver, you have excellent analgesia. But then maybe the patient doesn't require that much of morphine. The patient doesn't require that much of fentanyl or opioids. So we have to move away from this. We have to refine our techniques. So that is why all this thing is about. So these are some of the popular combinations. I'm sure most of us have tried ketamine and midazolam. We have used propofol and ketamine. We have used ketamine and dexmed. We have used ketamine, propofol, and dexmed together. And we have also used propofol and dexmed. So these are all various combinations. You can always add lignocaine to it and the other adjuncts also. So magnesium sulfate, you give a loading dose of 30 to 50 milligram per kg and a maintenance dose of 5 to 10 milligram per kg. If you use that, then your requirement of other drugs goes down by 10 to 20%. And also remember, these dosage of magnesium sulfate does not seem to affect your neuromuscular blockade. The neuromuscular blockade is not prolonged because of this much dose, and the levels in the blood, the magnesium levels, do not rise with this dose. Lignocaine, again, this can be added, so loading dose of 1.5 to 2 milligram per kg, and again maintenance of 1.5 to 2 milligram per kg per hour. We have commonly used lignocaine for pain on injection with the propofol. It can be given as an infusion, and but again, as we were talking about heightened vigilance, you have to watch out for arrhythmias. Although being an antiarrhythmic, it can actually induce arrhythmias if the toxicity, if the levels increase. So how do I do it? I keep it simple, not mix too many drugs to begin with. A routine preoperative checkup, standard monitors. Now, the beauty of opioid-free anesthesia is that it can be practiced either with TIVA TCI or with inhalation-based anesthesia. As I said, that there are three components of anesthesia: amnesia, analgesia, and areflexia. So, amnesia, you can either use propofol through TIVA TCI, or you can use inhalation as you do. Analgesia, instead of giving opioids, you use these drugs as an infusion or through TCI, which is even better. And then we have the areflexia. So if your analgesia and amnesia is good for surface surgeries and peripheral surgeries, you don't require a muscle relaxant. But yes, there are certain surgeries where you do require a muscle relaxant anyways, whether you're using opioid based or you're not using opioid based. So you may use the muscle relaxants like your traditional technique for areflexia. I like to pre-medicate with midazolam 0.03 milligram per kg. Regional anesthesia is always preferred because that will bring down the dose of your other drugs, and you can use. I usually use propofol or propofol for induction in oxygen and air for maintenance. Now, either you can use inhalational or you can use propofol. The choice is yours. Now, what I do is I use either ketamine or dexmedetomidine. I don't use both. I use either ketamine or dexmedetomidine as my analgesic regimen. I dilute these drugs as 2 milligram per ml for ketamine or 2 microgram per ml for dexmedetomidine. So it just makes my life simple. I standardizes the volume calculation. So pre-medication I said midazolam plus glycopyrrolate 0.2 milligram. Now glycopyrrolate counteracts the bradycardia caused by dexmedetomidine and also is a pre-medicament used with ketamine decreases the secretions. So midazolam and glycopyrrolate. Then induction with propofol. Loading infusion, I gave a ketamine or dexmedetomidine, that is 1 ml per kg over 10 minutes, both of ketamine or either of ketamine or dexmedetomidine, and then I set it at a rate of 0.5 ml per kg per hour. Sorry, this should be rate should be 0.5 ml per kg per hour. So this is the maintenance dose that I keep on throughout the surgery. Usually I don't have to alter the dose, and this is usually sufficient for most of the surgeries. And especially you can come on the dosage also if you have given a regional block. Maintenance, as I said, analgesic maintenance rate is 0.5 milligram, 0.5 ml per kg per hour. Remember the dilution was either 2 milligram or 2 microgram per ml. A stable infusion. Then I come down to 0.25 ml per kg per hour, and dose adjustment is usually not required. So as I said, the it is 0.5 milligram or microgram per kg per hour. So the volume that we have calculated comes down to 0.25 ml per kg per hour. So here, if I say the rate is 0.25 ml per kg per hour, and here it is 0.25 ml per kg per hour when I am giving it. So that is what I do usually for maintenance. Uh, Rounding off for any of the things which have been missed, PCM and then sets towards the end of the surgery. The main analgesia is maintained by the systemic infusion of ketamine or dexmed, bolus only if it is required, and this usually provides a complete coverage, and also the regional blocks definitely help. So I like to switch off the infusions 15 minutes prior to completion of the procedure, and usually give a 1 or 2 ml propofol boluses for smooth emergence. Just it's like you have switched it off. The effect of neuromuscular blockade is waning, and the surgeon has to just take a stapler or two more sutures, and then suddenly when you're fine, you're ready to reverse the muscle relaxants. You've switched off inhalation or you switched off your propofol. The surgeon suddenly remembers, oh, I have to take two more stitches. So that is where your propofol comes in handy, 10 or 20 milligram of propofol, just to enable the surgeon to take those two sutures. So this is how I do it. So to put it in a snapshot, dilute to 2 milligram per ml or microgram per ml depending on ketamine or dexmed, 1 unit per kg over 10 minutes, which is 0.5 ml per kg for 10 minutes. Then it is 0.5 unit per kg per hour, which translates to 0.25 ml per kg per hour. So if you dilute these drugs as 2 per ml, that these are the infusion rates that you have to remember: 0.5 for loading and 0.25 ml per kg for your maintenance. So that is how I do it. Switch it off with this. Now, the main what do you say controversy or the main opposition for the use of opioid-free anesthesia came from the POFO trial. It was a multi-central trial halted prematurely due to severe bradycardia and hypoxemia in the opioid-free anesthesia group. In fact, there were two asystoles also. Now, this was when they had used dexmedetomidine. Now, they had used dexmedetomidine in a dose of 1.4 microgram per kg bolus and an infusion going up to 1.2 to 1.6 microgram per kg per hour. So, once they reduce it to less than 1 microgram per kg, bolus and maintenance, there were no further incidences of bradycardia. But their ethical committee asked them to stop the trial. So, the take home message from this is that it is not that dexmedetomidine will cause bradycardia. Yes, it might cause bradycardia. You have to be vigilant, but then the life threatening arrhythmias are not there if you keep the dose of dexmedetomidine to less than 1 microgram per kg. It usually does not cause any significant disturbance and does not cause severe bradycardia. Okay, so as I've said, there's a relative risk of 1.9 to bradycardia. Hypertension may occur, so it is better to preload the patient, and small boluses of ephedrine or mefedrine may be required intraoperatively, as you would do it for spinal anesthesia. Yes, it is a bit complex. It's a new thing. We have to learn new things. There are infusions, there are lines going in, but then it does reduce the incidence of opioid incidence, respiratory depression, which is as high as 0.3 to 46%. So this major threat is eliminated from the armamentarium. So what is good? Is it opioid based or opioid free or opioid sparing? Studies have shown that probably opioid sparing is the best. That is an optimal reduction of 40 to 80% of opioids. You add other drugs along with opioids, and then probably you can achieve this balance. But then again, opioids sparing anesthesia again might be challenging. So why are we not practicing it? It's like I felt like a first year resident again. You have to be crazy to start doing that. So that is the thing. There's a loss of familiarity. We have been trained to use opioids throughout. You require a bit of more vigilance. You just can't sit and chat on your WhatsApp or watch videos and reels and shorts. So you have to have your eyes on the monitor. And then obviously, this even a 5 to 10 minute delay, the surgeon becomes impatient. The patient is on the table. I mean, if it weren't for us, they will jump on the patient and open up their palm as soon as the patient is on the table. They don't have patience. So that 5 minutes you have to have this, you have to show how well their patient is doing and why it is important for you to have those 5 to 10 minutes extra for anesthesia. Yes, there are certain knowledge gaps, oncological and immune impact, which I talked about. Chronic pain prevention, there have not been many studies regarding that. Obviously, we require more large scale RCTs for opioid-free anesthesia and opioid-sparing anesthesia. As I said, severe bradycardia, there has been only this POFA trial, which has put the entire opioid-free anesthesia into disrepute. I've been doing it for the last 6 years or so, 6 to 7 years, and luckily I have not had any life-threatening bradyarrhythmia with this, probably because I use glycopyrrolate as a pre-medication. Then again, we have to look at responders versus non-responders for pharmacogenomics, because there is an odd patient who complains of pain even after when you have given ketamine, dexmedetomidine, lignocaine, and other drugs as well. And that small touch of opioid is required to relieve pain. So probably it's the pharmacogenomics we need to study more. So the key takeaways in clinical pearls are that it is always a multimodal foundation. Dexmedetomidine or ketamine are the backbone agents. You have to be vigilant regarding the high hemodynamic changes. Uh, Opioids should be used only if absolutely required, and obviously you have to consult the patient. If you consult them, then definitely the need for postoperative opioids also decreases. So whether it's a myth, no, it's not a myth. OFA is definitely feasible. It is not fantasy. It is not unsafe. It has been successfully used for most of the major surgeries. In fact, I've totally eliminated opioids from my bariatric practice and thoracic practice. So I totally go opioid free in these patients. Yes, there are protocols, methods are there. There are different regimens which are there, but yes, work needs to be done. So future, definitely, even for, we can do it. See, the thing is that we have to come out, okay, this is the gold standard. Why can't we have a new gold standard? So we have to study more, we have to find out more evidence, and then we can say definitely it is the future, because even the ERAS protocol says that if you can eliminate opioids, the quality of recovery and the discharge times are faster. So to conclude, if we compare opioid free, opioid sparing, and opioid based, PNV reduction is best with opioid free. Quality of recovery is best with opioid sparing, although opioid free is not far behind. Safety and stability, slight vigilance is required with opioid free, but not that unsafe. Pain control, obviously, if we see the overall this thing, uh, they are more or like comparable. So if you really want to practice it, my advice would be you don't go opioid free directly. You start with opioid sparing and then move on to opioid free. So everything is difficult unless you practice, and once you practice, nothing is difficult. These are my references, and thank you for it. I'm open to questions. I'm willing to take any questions that you might have. Thank you.
Thank you so much, sir, for taking out your important time and sharing your insight and knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions. With all your permission, shall we
Yeah,
take
sure.
these questions?
Sure, sure.
First question is, sir, does the prevention of opioid-induced hyperglycemia (OIH) via OFA provide a clinically significant improvement in long-term chronic pain outcomes,
Faraz, your
or it's
voice
a
is
benefit
breaking.
limited
Your voice is
strictly?
breaking, Faraz.
Sir, I am repeating the question. Now am I audible?
Yeah, your screen is freezing. Yeah, tell me.
So the question is, sir, does the prevention of opioid-induced hyperglycemia via OFA provide a clinically significant improvement in long-term chronic pain outcome, or it's a benefit limited strictly to immediate reduction of post-operative nausea and vomiting, sir? What's your point of view on that?
So the thing is, there is evidence that it does provide relief in chronic pain as well, uh, although we don't have very large studies. See, the thing is, the main cause of chronic pain is inadequate relief of acute pain. So yes, it has a benefit in acute pain. Opioid-induced hyperalgesia is definitely reduced, but regarding the incidence of chronic pain with opioid-free anesthesia, whether there's an actual benefit or not, we still require studies. But yes, initial studies have shown that yes, it does have a place, and there is evidence to show that there is a reduction in um, chronic pain with the use of opioid-free anesthesia.
Thank you so much for sir answering this question, sir. We have another question, sir. Does the pharmacological complexity of triple drug non-opioid infusions unacceptability delay emergence and cognitive assessment, sir? What's your point of view on that?
Not really. See, again, as I said, you start it simple. You start with one drug, you add adjuncts, like you use either dexmedetomidine or you add ketamine, and probably you can add lignocaine. Lignocaine, I'll take it as an adjunct because it does not have much sedative effect or much cognitive effect. So you can add lignocaine, magnesium sulfate, and PCM along with regional blocks. Uh, the delay again, you have to be familiar with the pharmacokinetics. What is the duration of action of each drug? How much before you have to stop it? So the cognitive function, the assessment might be delayed with the use of morphine also. It can be delayed with fentanyl also. So it all depends how you use your drug. So that is just a myth that it delays recovery and the patient won't be awake. It will take a longer time to waken up the patient. So that is just a myth. The patient wakes up just fine.
Okay, thank you
In
so
fact,
much,
with
sir,
a
for
much
answering the
clearer
questions.
cognition than with opioids.
Yes, sir. Thank you so much, sir, for sharing insights to this question, sir. I hope it will be very much helpful to all the participants. Sir, as there is no more questions, sir, with all your permission, shall we conclude this discussion for today?
Yeah. Thank you. Thank you so
Yeah,
much.
it was great honor to host you, sir, and we would like to see you in future also with different topic. Till then, take care of yourself, sir. Thank you.